ovarian arteries enter such suspensory ligaments, of the ovaries. They terminate by the bifurcation into the ovarian and oval branches. The ovarian arteries pass through the mesothelium to the ovary. They are anastomos with the corresponding branches of the uterine artery, which is a branch from the internal iliac artery. From the ovary pass around the veins. They form wine-like pampiniform plexus, so it's similarly like in the testis. So pampiniform plexus of veins in the broad ligament of uterus near the ovary and the uterine tube. Next, they form usually a singular ovarian vein, which leaves the lesser pelvis with the ovarian artery. So, in the suspensory ligament of the ovary. The right ovarian vein ascends to enter the inferior vena cava. The left ovarian vein drains into the left renal vein. So look, one more time. Right ovarian vein drains directly to the inferior vena cava. The left ovarian vein firstly drains the left renal vein and left renal vein to the inferior vena cava. So look, on the left side, left renal vein to the left renal vein drains left ovarian vein and also the suprarenal vein. Yes? So on the left side differs from the right side. On the right side, the right ovarian vein or the right suprarenal vein, they drain directly into the inferior vena cava. It's a good question, yes, about the renal veins. Drainage of the lymph from the ovaries. So the lymph passes to the lumbar lymph nodes. We remember that we have the aortal, the caval, and intermediate. But in general, we call it the lumbar lymph nodes. So look, if we imagine, yes, that for example, there is a cancer of the ovary, very quickly the metastases are present in the lumbar, in the lymph nodes. So it's a very fast killer for the women, and it's very difficult to treat it, yes, because where the lymph nodes are affected, it's generally it's difficult to treat it, yes. So it's a fast killer, yes, because directly from the ovary, yes, to the lumbar lymph nodes, and it's very difficult to find such a cancer. So it's a big problem for the gynecologist and oncologist, of course. The nerves of the ovaries, the sympathetic and afferent fibers, they reach the ovarian plexus by descending along the ovarian vessels. Yes? So the ovarian artery and vein, and via communications from the pelvic, so the uterovaginal plexus. Parasympathetic fibers are from the pelvic splanchnic nerves, which arise from the ventral primary rami of the S2, S3, and S4. Afferent fibers from the ovary enter the spinal cord through the T10 and T11 nerves. The next structure, which belongs to the female genital organs, is a uterine tube. Uterine tube, which also is called the salpinx or fallopian tube. It extends laterally from the uterine horn, and opens into the peritoneal cavity near the ovary. So near this tubal end. Yes. Approximately is 10 centimeters long, lies in the mesosalpinx formed by the free edge of the broad ligament of the uterus. Uterine tube is a site of the conception. It conveys fertilized or unfertilized, yes, it depends, oocyte to the uterus by ciliary action and muscular contraction, which takes 3 to 4 days. The uterine tube has 4 parts. The first is an infundibulum, so it's a funnel-shaped distal end. It opens into the peritoneal cavity through the abdominal ostium. Has a finger-like processes of the fimbriated end, so fimbria. So look, it's opened to the abdominal cavity. So I told you that, for example, the bacteria, yes, can run, yes, through the vagina, through the uterus, through the uterine tube, and can achieve the abdominal cavity, because uterine tube, it opens, yes, to the abdominal cavity, to the pelvic cavity, yes. Ampulla is the widest and longest part. All sites expelled from the ovaries usually are fertilized in the ampulla. I need to emphasize it, yes, because very often I like to ask about it. Isthmus is a thick-walled part. It enters the uterine horn. And the last part, the uterine part, so I can't show you because it passes through the wall of the uterus. So this is the short intramural segment. It opens through the uterine ostium into the uterine cavity. So here you can see this abdominal ostium of the uterine tube. Yes, we can see the fimbriae, yes, and the infundibulum. Here is this widest part, yes, so the ampulla of uterine tube, and this is the isthmus, yes. Look here, we can see the ovary. Uterine tube is supplied by the 2 sources. Yes, one of them is from the uterine artery. So the branches, the tubal branches from the uterine artery. And the second source is from the ovarian artery. So the tubal branches from the ovarian artery. And the tubal veins drain into the ovarian veins or uterine venous plexus. Yes, so to the both directions. Yes, or uterine venous plexus or the ovarian venous plexus. And next to the left ovarian or right ovarian vein. And the same, so the lymph is drained to the lumbar lymph nodes. The nerves of the uterine tube derive partly from the ovarian and uterine plexus. So from the both plexuses, afferent fibers ascend through the ovarian plexus and the lumbar splanchnic nerves to the cell bodies in the T11 through L1 spinal ganglia. So for the ovary it was T10, T11, here T11, L1 spinal ganglia. The next organ, it's a uterus. It's an organ of the incubation and parturition. It's a thick-walled, pear-shaped, hollow muscular organ. It's approximately 7.5 centimeters long, 5 centimeters broad, and 2 centimeters thick, and weighs approximately 90 grams. During pregnancy, the uterus enlarges greatly to accommodate the fetus. Uterus lies in the lesser pelvis. Body of uterus lies normally on the top of the urinary bladder. Yeah, there is a urinary bladder. Neck, the cervix, lies between the urinary bladder and the rectum. Position of uterus changes with the degree of fullness of the bladder and rectum. Uterus has in general, we can say that it has this bigger part, the body and the cervix, but here we divide this uterus into the fundus, the body, the largest part, and the isthmus. So, what is the body? The body is the rounded part which lies superior to the orifices of the uterine tubes. So, here the fundus is the place for the fertilized egg. Body is the main part which is located inferior to the fundus and superior to the isthmus. Isthmus is the relatively constricted region, approximately 1 centimeter long, just above the cervix, between the body and cervix. Cervix, it's a cylindrical, narrow inferior part which protrudes into the uppermost vagina. Look, here this is vagina. So we have the two parts, yes, the supravaginal vaginal and vaginal part of the cervix of uterus. Body of the uterus lies between the layers of the broad ligament. It's freely movable, and it has the two surfaces, the vesical surface and the intestinal surface. The uterine horns of the uterus are, there are superolateral regions where the uterine tubes enter. The uterine cavity is a triangular shape in coronal section. So we can put a stick here, yes, so you need to write the uterine cavity. The cervix of the uterus is approximately 2.5 centimeters long in adult non-pregnant women. Cervix of uterus has two parts. So look, this first part, it's a supravaginal part, which is separated from the bladder anteriorly by the loose connective tissue, and from the rectum posteriorly by the recto-uterine pouch, so this Douglas cavity. The vaginal part of the cervix of the uterus is rounded and extends into the vagina and communicates with the external os. So external os is here. Yes. Sometimes we put a stick here, so you need to write as the external os of uterus. The cervix of the uterus has a cervical canal, so also the stick could be put here, so you need to write the cervical canal of uterus. The uterus has three layers, yes, so the outside is a perimetrium. Its outer serous coat consists of the peritoneum, supported by the thin layer of connective tissue. Myometrium is the middle muscular cord greatly distended during pregnancy. It contains the main blood vessels and nerves of the uterus, several smooth muscle layers. So look, the several smooth muscle layers. And the endometrium. So it's an inner mucous coat, firmly adherent to the underlying myometrium. It's a single layer. The broad ligament of the uterus is a double layer of the peritoneum. So we know that the uterus is it has an intra-abdominal position, yes? So it's the intra-abdominal organ. The broad ligament of the uterus extends from the sides of the uterus to the lateral wall and floor of the pelvis. It assists in keeping the uterus position. The broad ligament of the uterus has three parts. The first, it's a mesovarium. Unfortunately, I can't show you it now. I explain it, yes, that this is not a 3D picture, yes. So, but I promise during our labs, you will see it, yes, such mesovarium. It suspends the ovary. Mesosalpinx forms the mesentery of the uterine tube, and mesometrium, the biggest part of the broad ligament of uterus. So mesometrium, it's a mesentery of the uterus, and is located below the mesosalpinx and the mesovarium. And the round ligament of the uterus, it lies antero-inferiorly between the layers of the broad ligament of uterus. It's located in front and below the attachment of the uterine tube. So look, the uterine tube is the highest structure, yes, which starts from the lateral horn of the uterus. Posteriorly to it and slightly inferior will be the ovarian ligament, yes. Now they remove slightly below, yes, the uterine tube to show us such ovarian ligament. And the round ligament of uterus is located antero-inferiorly, yes, and is visible in our specimens, so you will see it, yes. So you need to recognize these three structures which start from the lateral horn of the uterus. The round ligament of uterus, it ends in the labium majus. The position of the uterus in the median plane, so it's located at the center of the pelvis, with the vaginal part of the uterus level, with a line which connects the two ischial spines. So the uterus is located in the center of the pelvis, yes? So in the median plane. And the uterus has a curvatures. So we can say that the uterus, of course, was physiological position, yes, so normal position, yes. So uterus normally should be anteverted and anteflexed. So anteverted, yes, this yellow color. So anteverted, it's version. So it's an inclination of the cervix in the pelvic cavity is defined by the angle between the cervical axis and the vagina. So look, it's formed the angle, yeah, and it's between the cervix and between the vagina. So anteverted uterus, yes. So it's correct position, yes, of the uterus. The second one, it's an anteflexed flexion. It's an inclination of the uterine body relative to the cervix. So this green color, between the green and yellow, yes, is defined by the angle between the longitudinal axis of the cervix and the uterine body. So anteflexed and anteverted. The principal supports of the uterus, they keep the uterus centered, so we remember that it's the median plane, so they keep the uterus centered in the pelvic cavity and resist the tendency of it to fall or be pushed, yes, through the hollow tube formed by the vagina. But look, we can find some different position, yes, of the uterus, and it isn't normal position, yes, of uterus, yes, because, for example, this one, yes, are not in the center, yes, of the pelvis, or this uterus, or this, they are more, this is above and this is below the line which connects ischial spines. So principal supports of the uterus are dynamic or passive. Dynamic is provided by the pelvic diaphragm, the tonus during sitting and standing, and the active contraction during periods of increased intra-abdominal pressure, yes, which is transmitted to the uterus through the surrounding pelvic organs, yes, like a urinary bladder, the rectum, and the endopelvic fascia. The passive support is provided by the position of the uterus, so the way in which normally the anteflexed and anteverted uterus rests on the top of the bladder. So anteflexed and anteverted. So passive supports of the cervix are the condensations of the endopelvic fascia, the ligaments. So there are two ligaments, the transverse cervical, or they are also called the cardinal ligaments of uterus, yes, the transverse cervical cardinal ligaments, and the uterosacral ligaments. Here you can see uterosacral ligament. So passive, the transverse cervical, such cardinal ligaments, they extend from the cervix and the lateral parts of the fornix of the vagina to the lateral walls of the pelvis. And the uterosacral ligaments, this one, they go up, yes, here. They pass superiorly and slightly posteriorly from the sides of the cervix to the middle of sacrum. They are palpable during the rectal examination. So the per-rectum examination. Anteriorly and superiorly, except the vaginal part of the cervix, the uterus is completely covered with the peritoneum. Posteriorly, the peritoneum reflected over the posterior part of the fornix of the vagina, to the rectum. So here we remember it's a recto-uterine pouch, this Douglas cavity. So the anteriorly to the uterus is located the vesico-uterine pouch and the superior surface of the bladder. So here it's a vesico-uterine pouch, yes, and the superior surface of bladder. Posteriorly, so look, this deepest, yes, the recto-uterine pouch, this Douglas cavity, which contains loops of the intestine and is related to the anterior surface of the rectum. Laterally to the uterus is a peritoneal, this broad ligament of uterus, this cardinal ligaments, this transverse cervical ligaments, the ureters, which enter the urinary bladder, and the uterine arteries. The uterus generally is supplied by the uterine arteries. An additional supply is by the ovarian arteries, but in general, yes, the uterine arteries, they supply the uterus. There are branches from the anterior division of the internal iliac artery. The uterine artery runs medially in the base of the broad ligament, superior to the cardinal ligaments, and they cross this superiorly the ureter. So I explain it, yes, now you have it, yes, that the water is in the ureter, yes, and the uterine artery is a bridge, yes, so the artery passes over the uterus. But firstly, look, firstly we can see, I'm sorry, here the uterine artery, yes, passes firstly laterally, yes, to the uterus, and to the uterus, to the, sorry, I'm so sorry, ureter, and next it passes above the ureter. The blood from the uterus is the blood from the uterus is formed by the uterine plexus and of course on the each side of the cervix of uterus, and the blood next form the vessels next are formed to the internal iliac vein through the uterine vein. So uterine vein, and next the internal iliac vein, next the common iliac vein, and the inferior vena cava. And what is important that the lymphatic drainage of uterus, because we can find the three different directions, yes, of the pathway of the lymph. So, from the fundus of the uterus, the lymph passes to the lumbar lymph nodes. So, look, it's similar like from the ovary and from the uterine tubes. Yes, that. So from the ovaries and uterine tubes, yes, and the fundus to the lumbar lymph nodes. So if there are some metastases, yes, so metastases quickly achieve the lumbar lymph nodes. Some vessels can pass to the external iliac lymph nodes or along the round ligament of the uterus to the superficial inguinal lymph nodes. So, why it happens? Look, the round ligament of uterus, which starts from the lateral horn of the uterus, it passes through the inguinal canal, yes, and enters, leaves the inguinal canal through the exit of the inguinal canal, and here we have the superficial inguinal lymph nodes. Yes, the round ligament of uterus, it ends in the labium majus. So, if it is present, the cancer of the fundus of the uterus, sometimes the superficial inguinal lymph nodes could be enlarged. So we need to remember, yes, if we have enlarged superficial inguinal lymph nodes, that there is not only something in the external genital organs or the anal canal, but it also could be from the fundus, yes, from the fundus of uterus. Next pathway, it's from the uterine body to the external iliac lymph nodes, and from the uterine cervix is to the internal iliac and the sacral lymph nodes. We can see it, the sacral lymph nodes and the internal iliac lymph nodes. The uterovaginal plexus of the uterus extends to the pelvic viscera from the inferior hypogastric plexus. It contains the sympathetic, parasympathetic, and the visceral afferent fibers. The nerves travel with the uterine artery at the junction of the base of the peritoneal broad ligament and the superior part of the cardinal ligament. The sympathetic innervation of the uterus originates in the lower thoracic spinal cord segment and passes through the lumbar splanchnic nerves and the intermesenteric, the hypogastric plexuses to the uterus. Parasympathetic, remember, S2, S3 and S4. So spinal cord segments and passes through the pelvic splanchnic nerves to the inferior hypogastric and next the uterovaginal plexus. The visceral afferent fibers of the uterus, they conduct pain impulses, so from the intraperitoneal uterine fundus and the body follow the sympathetic innervation to reach cell bodies in the lower thoracic or upper spinal ganglia. From subperitoneal uterine cervix follow the parasympathetic fibers to reach the cell bodies in the spinal ganglia of the S2, S3 and S4. I need to return, I'm so sorry, I do it very quickly because I forgot to tell you about something. I need to emphasize, I have no idea what question I will give you during the credit, but I need to emphasize one more time. Remember, the place of the fertilization, yes, is in the ampulla of uterine tube, but what is very important, and I'm sure that I didn't tell you about it, it's implantation of fertilized egg into the endometrium of the uterus is the best place. It's very dangerous where implantation will be lower, yes, in lower parts of the uterus, yes, because look, we need to remember that is formed the placenta, yes, the placenta. So the best place, yes, for it, yes, is in the fundus of the uterus, yes. So remember, implantation, the best place is in the fundus of the uterus. I have no idea, maybe it wouldn't be such a question, yes, but it's better to tell you about it. Okay, and let's go. So, now the vagina. So vagina, it's an organ of copulation and parturition. It's a muscular membranous tube that's 7-9 centimeters long. It extends from the cervix to the vestibule of the vagina, the cleft between the labia minora. So remember this term, the vestibule of the vagina. The superior end of the vagina is surrounded by the superior end of the vagina surrounds the cervix of the uterus. The lower end of the vagina passes antero-inferiorly through the pelvic floor to open the vestibule of the vagina. Vagina serves as the excretory duct for menstrual fluid. Forms the inferior part of the pelvic, the birth canal, and receives the penis and ejaculate during the sexual intercourse. Vagina communicates superiorly with the cervical canal and inferiorly with the vestibule of the vagina. I need to emphasize it, yes, because this term is very important, the vestibule of the vagina. Vagina is located posteriorly to the female urethra and the urinary bladder. Anteriorly is located to the rectum and the anal canal and the recto-uterine pouch. Between the medial margins of the levator ani muscles and the visceral pelvic fascia and the ureters. Vaginal fornix is a recess around the cervix of the uterus. So we can find the anterior, posterior, and the lateral parts of the vaginal fornix. The posterior vaginal fornix is the deepest part and is closely related to the recto-uterine pouch. So the most important is this posterior fornix, posterior vaginal fornix, because it's related to the Douglas cavity, to the recto-uterine pouch. The muscles which compress the vagina, they act like sphincters. We can find the 4 muscles which compress the vagina. So the pubo-vaginalis, the external urethral sphincter, the uretro-vaginal sphincter, and the bulbospongiosus sphincter. And the bulbospongiosus, I'm so sorry. The superior part of the vagina is supplied by the uterine artery, so the branches from the uterine artery. The middle and inferior part of the vagina is supplied by the middle rectal artery and the internal pudendal artery. Of course, there's 3 vessels, the uterine artery, the middle rectal artery, and the internal pudendal artery. There are branches from the internal iliac artery. So, if you remember the big source, yes? So you will remember the next vessels, yes? The internal iliac artery, and it gives these three vessels: uterine artery, the middle rectal artery, and the internal pudendal artery. Vaginal venous plexus is located along the sides of the vagina and within the vaginal mucosa. It continues with the uterine venous plexus as a uterovaginal venous plexus. Drain into the internal iliac veins, on the both sides of course, through the uterine vein. So uterine vein collects blood from the vagina, and next it drains into the internal iliac vein, yes? Communicates with the vesical and rectal venous plexuses. From the superior part of the vagina, the lymph is drained into the internal and external iliac lymph nodes. From the middle part into the internal iliac lymph nodes. And from the inferior part into the sacral lymph nodes, common iliac lymph nodes, as well as into the superficial inguinal lymph nodes, which could be enlarged, remember, also where the fundus of the uterus is affected. The nerves of the vagina are from the uterovaginal plexus to the upper 3/4 to 4/5. From the pudendal nerve by the deep perineal branch. This deep perineal branch, it conveys sympathetic and afferent fibers, but not parasympathetic fibers, to lower 1/5 or 1/4. So generally we can say that the bigger part, the upper part, is supplied from the uterovaginal plexus. This lower part of the vagina is supplied by the pudendal nerve, especially the branch of it, the deep perineal branch. Now, shortly, let's talk about the female external genitalia. So, we can find the mons pubis, the labia majora, the labia minora, clitoris, vestibule of the vagina. The bulbs are not visible here of bulbs of vestibule, and the greater vestibular glands. So, mons pubis is rounded, fatty prominence, anterior to the pubic symphysis, pubic tubercles, and the superior pubic rami. Labia majora are the copulatory organs, yes. Labia majora are the longitudinal folds of skin. They bond the pudendal cleft and indirectly provide the protection for the urethral and vaginal orifices. Labia majora pass infero-posteriorly from the mons pubis toward to the anus. They join to form the anterior labial commissure. Labia majora contain smooth muscles and fat, and they are homologous to the scrotum of male. And remember that in the labia majora and the round ligaments of uterus. So now you can see it, yes. So the round ligament of uterus, yes, is prepared here, yes, and we can see that it ends in the labium majus. Labia minora are also the copulatory organs. The labia minora are the folds of fat, but there are 3 hairless skin. Yes? They enclosed in the pudendal cleft within the labia majora. Labia minora surround the vestibule of the vagina. Here it's a vestibule of the vagina. And labia minora, they fuse to form the prepuce of the clitoris. Labia minora extend from the clitoris posterolaterally around the external urethral orifice and the orifice of the vagina. Clitoris is an erectile organ which is located where the labia minora meet anteriorly. Clitoris consists of a root, a body, and is composed of two crura, two corpora cavernosa, and a glans of a clitoris that is covered by a prepuce. Clitoris is highly sensitive and is homologous to the penis in the male. The vestibule of the vagina is a space between the labia minora. Vestibule of the vagina contains the openings of the urethra, vagina, and the ducts of the greater and lesser vestibular glands. They product a secretion, and on each side of the external urethral orifice are openings of the ducts of the paraurethral glands. The thin fold of the mucous membrane, it surrounds the vaginal orifice, and after childbirth, so we can find a few remnants, so the hymenal caruncles. Remember this term, the hymenal caruncles, the gynecologists use it, yes, hymenal caruncles. Bulbs of vestibule, they are paired masses of elongated erectile tissue. They lie along the sides of the vaginal orifice, undercover the bulbous spongiosus. Look, here we have a we can see the fibers of the bulbous spongiosus muscle, yes, and on this side we can see this bulb of the vestibule. It's homologous with the bulb of penis and corpus spongiosum. Female urethra is approximately 4 centimeters long and 6 millimeters in diameter, passes antero-inferiorly from the internal urethral orifice of the urinary bladder, posterior and then inferior to the pubic symphysis. The external urethral orifice is located in the vestibule of the vagina, okay, directly anterior to the orifice of the vagina. Passes with the vagina through the pelvic diaphragm, external urethral sphincter, and the perineal membrane. Now we need to talk about some terms like a pelvic diaphragm and the urogenital diaphragm. Pelvic diaphragm forms the funnel-shaped or hammock-like floor of the pelvic cavity. Pelvic diaphragm consists of the levator ani muscle, the coccygeus muscle, and the fasciae, which cover the superior and inferior aspects of these muscles. Pelvic diaphragm separates the pelvic cavity from the perineum. Pelvic diaphragm stretches between the pubis anteriorly and the coccyx posteriorly, and from one lateral pelvic wall to the other. So here it's a male pelvic diaphragm and the female. The levator ani muscle is a broad muscular sheath, yes? It's a larger part and most important muscle in the pelvic floor. It attaches to the internal surface of the lesser pelvis. So levator ani muscle is the main muscle of the pelvic diaphragm. Levator ani muscle is composed of the three parts. The pubococcygeus, the main part, it arises from the posterior aspect of the body of the pubis and passes back almost horizontally. The iliococcygeus, the posterior part, is thin and often poorly developed, and the puborectalis part, so this puborectalis part, it's thickened, medialmost part of the pubococcygeus. It unites with its partner to form a U-shaped muscular sling that passes posterior to the anal-rectal anorenal junction. Levator ani muscle, the proximal attachment is to the body of pubis, tendinous arch of the obturator fascia. Here you can see the obturator internus muscle. We will talk about this muscle with the lower limb and the ischial spine. The distal attachment is in the perineal body, the coccyx, the anococcygeal ligament, walls of prostate or vagina, the rectum, and the anal canal. Levator ani muscle is innervated by the nerve of the levator ani, the nerve to the levator ani, so it's a branch of the S4. The inferior anal rectal nerve and the coccygeal plexus. What is the function of the levator ani muscle? So it helps to support the abdominopelvic viscera. So look, it's a very important muscle because it protects the organs, yes, which are located in the pelvic cavity. It resists increases in the intra-abdominal pressure, helps to hold the pelvic viscera in the position, and important function in voluntary control of urination, fecal continence, and defecation. The second muscle, which forms the pelvic diaphragm, it's a coccygeus, or sometimes it's called the ischio-coccygeus muscle. So it's a smaller one. It extends from the ischial spine to the inferior end of sacrum. It's innervated by the branches or S4 and S5 nerves, so from the sacral plexus. And the main action forms a small part of the pelvic diaphragm that supports the pelvic viscera, and it also, because it's attached to the coccyx, so it flexes coccyx. Here. The ischioanal or ischiorectal fossa, so both terms are correct, yes, ischioanal or ischiorectal. So the large fascia lined the wedge-shaped space which is located between the skin of the anal region and the pelvic diaphragm. The apex of the ischioanal or ischiorectal fossa lies superiorly where the levator ani muscle, look, this is the levator ani muscle, so where the levator ani muscle arises from the obturator fascia. This is the obturator internus muscle. Here is this fascia of this muscle, and this is the apex of such ischioanal, ischiorectal fascia, fossa. This fossa is wide inferiorly and narrow superiorly. Is filled with the fat and loose connective tissue. Ischiorectal fossa communicates by means of the deep postanal space over the anococcygeal ligament. What are the boundaries of the ischioanal fossa? So laterally is the ischium and the inferior part of the obturator internus muscle. Look, this is the obturator internus, which is covered with the obturator fascia. Medially, there is the anal canal. Posteriorly, the sacrotuberous ligament and the gluteus maximus, which belongs to the buttock. And anteriorly, there is the external urethral sphincter and the deep transverse perineal muscles and their fascia. And what will be important? This wall, yes, so this lateral wall. Why? I will explain. So the lateral of the ischioanal fossa contains the internal pudendal vessels and the inferior rectal vessels and the pudendal nerves. Pudendal nerves, which are branches from the sacral plexus. The perforating branch of the S2 and S3 and the perineal branch of S4 nerve pass through this lateral wall. So, here is located the pudendal canal on such lateral wall of this ischioanal, ischiorectal fossa. So it's a space within the obturator fascia which covers the medial aspect of the obturator internus and lines the lateral wall of the ischioanal, ischiorectal fossa. The internal pudendal artery, which is a branch from the internal iliac artery, and the vein which will return to the internal iliac vein, the pudendal nerve, which is a branch from the sacral plexus. Look, here it's a sacral plexus in the pelvic cavity, and the nerve to the obturator internus enter this canal at the lesser sciatic notch, inferior to the ischial spine. Here, this is the ischial spine, so inferiorly to it, yes, pass these structures. Pudendal nerve is derived from the anterior divisions of the ventral rami of S2, S3, and S4, the pudendal nerve. It accompanies so look, this is this green color, yes, and it accompanies the internal pudendal artery and of course vein. Pudendal nerve, it's a main nerve of the perineum and the chief sensory nerve of the external genitalia. We need to remember about it because it's a possibility to make a pudendal nerve block. So it's an injection, a local anesthetic near the pudendal nerve. So yeah, we can perform the injection, yes, through it, and we can make a pudendal nerve block. Pudendal nerve. So here, this red color, yes, it's written, yes, with the red color. So pudendal nerve, which leaves this pudendal canal. Next, it splits, giving rise to the perineal nerves. So here, this is the place, yes, where we can perform this pudendal block nerve. So pudendal nerve, it splits to the superficial, the scrotal or labial, it depends on sexes, branches, and the deep nerves, so to the muscles of the perineal pouches, the skin of the vestibule of the vagina, and the mucosa of the inferiormost part of the vagina. So we can perform this block when we need to suture, yes, after the childbirth, we can make this nerve block, yes, to suture the skin and the structures. The inferior nerve arises at the entrance of to the pudendal canal and supplies the external anal sphincter and the perianal skin. Pudendal nerve ends as a dorsal nerve of the penis or clitoris. So there are sensory branches. Let's talk shortly about the anal canal, because we talk with the gastrointestinal tract only about the rectum, but we remember that to the rectum also belongs the anal canal, yes? So it's a terminal part of the large intestine. It extends from the upper aspect of the pelvic diaphragm to the anus, external outlet of the gastrointestinal tract. It has the 2.5 to 3.5 centimeters long. It begins where the rectal ampulla narrows at the level of the U-shaped sling formed by the pubo-rectalis muscle. Is surrounded by the internal and external sphincters descend postero-inferiorly between the anococcygeal ligament and the perineal body. The external anal sphincter is a large voluntary sphincter. So we have the influence on it, yes? Forms a broad band on each side of the inferior 2/3 of the anal canal. Blends superiorly with the pubo-rectalis muscle, is supplied mainly by the S4 through the inferior rectal nerve. The internal anal, look, this is the external anal sphincter, this is the internal anal sphincter. So it's an involuntary sphincter. It surrounds the superior 2/3 of the anal canal. A thickening of the circular muscular layer is innervated by the parasympathetic fibers that pass through the pelvic splanchnic nerves. So we remember that the parasympathetic fibers, they relax, yes, the sphincters. The internal anal sphincter tonically is contracted most of the time to prevent the leakage of fluid or flatus, and relaxes in response to the pressure, yes, of feces or gas distending the rectal ampulla. So the anal canal has two parts, the superior and inferior. Superior part is derived from the embryonic hinge gut, and the inferior is derived from the embryonic proctoduum. So look, here we have the end of the hinge gut, yes? So the embryonic hinge gut, this is the embryonic proctoduum, yes, proctoduum. The pectinate line, so this dentate or mucocutaneous line, is irregular line which indicates the junction of the superior part and the inferior part of the anal canal, and is formed by the inferior cone-shaped limit of the anal valves. And the part parts of such anal canal, they completely differ, yes, in the arterial supply, innervation, and the venous and lymphatic drainage. The superior part of anal canal is composed of the anal columns, a series of longitudinal ridges in the superior half of the mucous membrane. The anal columns contain the terminal branches of the superior rectal artery and vein. So look, the superior rectal artery, which is a branch from the inferior mesenteric artery. Yes? So here we have the connection, yes, with the portal venous system. Yes? So I explained that it's a possibility, yes, to have the varices, yes, in the anal canal, yes, where is the blockage in the portal venous system, but it's very rare, yes. The anal-renal rectal junction, indicated by the superior ends of the anal columns, so the rectum joins the anal canal. Anal valves, they join the inferior ends of the anal columns. And the anal sinuses, they are small recesses, they superior to the anal valves. So, one more time, let's look. So, the superior rectal artery, which is a branch from the inferior mesenteric artery, it supplies the superior part of the anal canal. The two inferior rectal arteries, so on the both sides, yes, because the internal iliac artery is paired, yes, so supply the inferior part of the anal canal. And the middle rectal arteries, they form the anastomosis with the superior and inferior rectal arteries. Middle rectal artery is also the branch from the internal iliac artery. So middle is between the superior rectal artery, which is only one. The middle and inferior are paired because there are the branches of the internal iliac artery. The internal rectal venous plexus drains in both directions from the level of the pectinate line. So, superiorly to the pectinate line, the plexus drains chiefly into the superior rectal vein, yes, and next to the inferior mesenteric vein. Inferiorly to the pectinate line, the plexus drains into the inferior rectal veins, so into the middle or inferior rectal veins, which next drain to the internal iliac vein, next to the common iliac vein, and next to the inferior vena cava, and we remember that it happens on the both sides because they are paired. Superiorly to the pectinate line, the lymph is drained into the internal iliac lymph nodes and through them into the common iliac and next the lumbar lymph nodes. Inferiorly to the pectinate line, the lymphatic vessels drain into the superficial inguinal lymph nodes. So look, the next organ where it happens, the cancer of the anal canal, the inferior part, yes, especially the anus, yes. So the metastasis could be present in the enlarged superficial and inguinal lymph nodes. So now let's collect our information of the lymphatic drainage. Yes. So from the superficial inguinal lymph nodes, we need to go through the deep inguinal lymph nodes, yes, deep inguinal lymph nodes which are present in the femoral canal. And next we can go to the external or internal iliac lymph nodes, or directly from the deep inguinal lymph nodes we have some vessels, lymphatic vessels, which drain directly to the common iliac lymph nodes, yes? So, 3 roads, yes? And next, from the common iliac lymph nodes to the left lumbar lymph nodes, and the lumbar lymph nodes, of course, the right are present, or we can call it in different division, so the aortic, caval, and intermediate. Yes. These lumbar lymph nodes, they form the lumbar trunk, yes, on right and left side. And these trunks, they drain into they form the chyle cistern. But from the parts of the gastrointestinal tract, yes, from the organs, yes, we remember about these supiomesenteric lymph nodes, which drain to the celiac lymph nodes, and from the celiac lymph nodes we have the intestinal trunks. So look, the lumbar trunks, the intestinal trunks, they form the chyle cistern, and next at the level of the T12 is formed the thoracic duct, and thoracic duct, it drains into the left venous angle. So I collected for you the information about the drainage from the abdominopelvic cavity. Anal canal, the superior part, is sensitive only to the stretching and has a visceral innervation from the inferior hypogastric plexus. You remember it's located on the both sides of the rectum, yes, and on the levator ani muscle. So inferior hypogastric plexus, which is composed of sympathetic and parasympathetic fibers. The inferior part is sensitive to pain, touch, and temperature, so has innervation from the inferior anal rectal nerves, which are branches of the pudendal nerve. Yes, pudendal nerve, which is a branch from the sacral plexus. So this one, sacral plexus, yes, in the pelvic cavity, and here we can see perfect the pudendal nerve, and this is the anal, inferior anal or rectal nerve. Of course, they are paired because we have the two sacral plexuses, yes. So, what organs we can find in the pelvic cavity or viscera, yes? Viscera, it means the organs. So, urinary bladder, the pelvic parts of ureters, the reproductive organs, and the inferior part of the intestinal tract, so the rectum. Remember that the sigmoid colon and the parts of the small bowel, which sometimes, so small intestine, which sometimes they could be found in the pelvic cavity, are not the pelvic viscera. So they could be present, yes, because the small intestine or sigmoid colon, they are movable because they have the sigmoid colon has a mesocolon, small intestine has a mesentery, so there are movable parts of the gastrointestinal tract, but they are not organs of the pelvic cavity. And the most difficult part of this lecture, today's lecture, so this is the perineum. and I will try to explain some pouches which are present here, but shortly, so let's start. Perineum is the area of the trunk between the proximal parts of the thighs and buttocks. It's a diamond-shaped area extending from the coccyx to the pubis. The shallow compartment lying deep to this area and inferior to the pelvic floor. So includes anus and penis and scrotum in male, or a vulva, so the external genitalia in female. Some obstetricians apply this term, the perineum, to a more restricted region, so the area which is located between the vagina and the anus, so only here. Because normally in anatomy, yes, we apply this term to these structures. Yes, here it's a perineum, but for the obstetricians, perineum, this is the more restricted region. Perineum is divided by the transverse line which joins the anterior ends of the ischial tuberosities into the anal triangle, which contains the anus, and the urogenital triangle, which contains the root of scrotum and penis in males, or external genitalia in females. Perineal body is the attachment for the perineal muscles. It's an irregular fibromuscular mass located in the median plane between the anal canal and anus and the vagina or bulb of penis. Perineal body attaches to the posterior border of the perineal membrane. Is overlaid by the central point, so the midpoint of the line joining the ischial tuberosities. Perineal body is the site of the convergence of the several muscles. It lies deep to the skin and subcutaneous tissue. Look, I will try to emphasize some the most important information about it. Yes, because I should be in a hurry because Dr. Ostrowski is waiting for the radiological part. So I will emphasize what is important, okay? I will open the door because there is a lack of oxygen. Okay, so perineal membrane, it stretches between the two sides of the pubic arch and covers the anterior part of the pelvic outlet. So the deep transverse perineal muscles immediately superiorly run transversally along the posterior aspect. The external urethral sphincter surrounds the urethra above the center. So to the perineal body belong the bulbus spongiosus muscle, external anal sphincter, and the superficial and deep transverse perineal muscles. The perineal fascia is divided into the superficial and deep. So superficial subcutaneous tissue of the perineum, and the deep perineal fascia, which is called the investing or Gold's fascia. The potential is the superficial perineal pouch. Look, is with this red color, yes, superficial perineal space or pouch, yes. So this one, yes, in male and female. So it's a potential space between the membranous layer of the subcutaneous tissue and the perineal membrane. So, superficial perineal pouch in males contains the root or bulb crura of the penis and associated muscles, the proximal part of the spongy urethra. So, the superficial transverse perineal muscles, the branches of the internal pudendal vessels, and the branches of the pudendal nerves. So the perineal nerves. So look, this is the superficial perineal space. In females contains the root, the crura of the clitoris and the associated muscle, the ischiocavernosus, bulbs of vestibule and the surrounding muscle, the bulbus spongiosus, superficial transverse perineal muscles, the branches of internal pudendal vessels, nerves, and the greater vestibular glands. So generally the structures which are located superficially. So now in female it's a superficial perineal fascia. And now I need to show you something because later maybe you wouldn't see this term, urogenital diaphragm. I need to emphasize it because sometimes we put a pin there, yes, the urogenital diaphragm. The assistants will show you it during the labs, yes, how we can put where we can put a pin into this urogenital diaphragm. So you need to see it, yes, in our specimens. So the deep perineal pouch opens superiorly, but it's not enclosed compartment with the deep urogenital muscles is bounded below the perineal membrane. It extends superiorly as an anterior recess of the ischioanal fossa. So here we will find the deep perineal pouch. So let's go. So deep perineal pouch in males contains, and look, this is important, yes, because this deep perineal pouch contains the membranous part of the male urethra, external urethral sphincter muscle, which is around this membranous part of the urethra. We remember that behind this membranous part of the urethra there are located the bulbourethral glands. Of course, here it's a deep transverse perineal muscles because on the both sides, and the related vessels and nerves. So look, if you find a pin, and it's easier to put a pin in male than in female, because in female through this diaphragm passes not only the urethra but also the vagina. So it's extremely difficult to put a pin. But in male, yes, it's easier to put a pin into the urogenital diaphragm. So anteriorly or posteriorly to this membranous part of the urethra. Of course, you wouldn't see this bulbourethral glands. Yes. So this urogenital diaphragm is a deep perineal pouch in males. Yes. In females, the deep perineal pouch contains the proximal part of the urethra, external urethral sphincter muscle, deep transverse perineal muscle, and the related vessels and nerves. And thank you very much. So see you on Friday. So we have different types of
write your names and names of the group meanwhile. And okay, so the second radioanatomic part of abdominal cavity, and today we will focus on the urinary system. And this is the picture according to the urinary system diagnostic method, which is called urography. You can also call it intravenous biliogram. It depends on the level of urinary tract we are focused on. So we are giving the radio contrast intravenously, and it is starts to be excreted by the kidneys about 3 minutes after the patient receives it, and we can watch how the kidneys excrete it. Of course, it's in urine, so it feels and makes visible first the kidneys, next the parts of the urinary tract. So we have each part which is visible. Here's a minor and major renal caries, for example, and this is a pelvis, and the next. We can observe if there's any constrictions or disorders in the way the urine passing each stage of the urinary system. Yes. How can we say which kidney is left and which is right? This is anterior-posterior X-ray. The left one is lower or higher than the right one. Left one is higher. And you can tell it not only looking at the superior extremity of the kidney, but also pelvis. So the left pelvis is always more superiorly located than the right one, for example. It corresponds with the first or second lumbar vertebra, speaking about the left and the right one. Yes? So it's quite easy. Double slide. Okay, and the next picture shows the CT scan of the abdominal cavity at the level of superior margins of pelvis. So we are at this level, and we have some structures that create anterior lateral and posterior wall of abdominal cavity, mainly muscles, which we can see here. For example, rectus abdominis muscle, the transversus abdominis muscle, and two oblique muscles, external and internal one. We have also muscles that create posterior wall of the abdominal cavity. So this is the quadratus lumborum, and at the both sides of the bodies of lumbar vertebra, at this level we have psoas major muscle. a little lower, and we have bony parts of the pelvis, such as ala of ilium, the muscle that fills its internal surface, covers it, which is iliacus muscle, a part of iliopsoas muscle. So the major psoas muscle and iliacus create iliopsoas one, and we have also a part that sacrum that, along with the ilium, creates sacroiliac joint. And we have a little lower, of course, this is the picture taken after the patient received radio contrast. So we have arteries which are contain, the blood with arteries contains much more radio contrast than vessels, that's why they are much whiter. We have also a viscera of greater pelvis, which are coils of large intestine, for example, here. And we have two common iliac vessels, the artery and a vein. And can you tell me what arteries, they are whiter, so it must be arteries, are those two? So, first, maybe this one. So, we are at the level where the abdominal aorta branched into two common iliac arteries, yes? Because we can see those two here. We can also see two common iliac veins. So we are lower than fifth lumbar vertebra, or at the level of the fifth lumbar vertebra. A little lower because we have a sacrum here. And at the posterior surface of the abdominis rectus muscle, which artery runs? Inferior epigastric artery. Inferior epigastric artery. And this one can be seen here and here. Which unpaired artery runs inferiorly, almost in the mid-sagittal line, and approaches rectum. This is a terminal branch of inferior mesenteric artery, superior rectal artery. So inferior, or to be more precise, the left inferior epigastric artery and superior rectal artery. And we can, at this picture, we can observe how the sigmoid cone turns into the rectum, partially filled with feces here. We can also see the terminal branches of the two common iliac artery and veins. So we have external and internal iliac arteries and veins, accompanying the arteries, of course. And this comes from the magnetic resonance. This method is much better to diagnose the soft tissue, especially those which are hidden behind the bony structures, because this is one of the disadvantages of CT, for example. This method is much better. For example, to diagnose the viscera of pelvis. This is the female pelvis, and we can see some of the bony structures. The white tissue that covers that surrounds the muscles are fat. This is fat. So the subcutaneous tissue mainly. And we have a bony structure such as ilium here and here. This is the superior surface of the urinary bladder. And we have a coils of small intestine. At this level, it can be jejunum. It must be ileum already. We have also rectum. anteriorly to the vertebral column. So the vertebral column is here. And also flexed to the right side uterus. To be more precise, the body of the uterus and the cavity is slightly touched also here. So the uterine cavity. And as we go a little lower, we can see the urine field, urinary bladder. Some bony structures also can be seen here, part of the hip joint, for example, the head of the femur, the structures that lies anteriorly to the iliopsoas muscle, which is here. So we have external iliac vein and artery, as well as the femoral nerve. Somewhere here should be also a femoral branch of the genitofemoral nerve. We can distinguish those using this method. We have also an obturator internus muscle, which creates the lateral wall of, covers the lateral wall of the pelvis, the lesser one, and we have urine field, urinary bladder here. Between the rectum and the urinary bladder in female we have also a uterus. This is the centrally located cervix with its canal here. So the cervix, cervical canal. And as we go a little lower, the cervix continues as a vagina. We have it here. It's anterior-posteriorly flattened structure with the slit-like volume. And we have also at the both sides, at the posterior lateral surface of the urinary bladder, we have two ureters approaching it. Here and here. Posteriorly to the vagina we have rectum, of course, and the muscles that surrounds it creates the narrowing of the ampulla and creating, of course, also the walls of the rectal canal, anal canal, so the anal part of the rectum, and we have also a fat-filled fossa, which is slightly better visible here, which fossa is this one. Between the levator ani muscle, the internal obturator one, and of course the anal canal. Ischio-anal fossa. And of course we have some structures such as pubic symphysis. This is the mons pubis, mainly composed of the fatty tissue. We have a pubic symphysis, and posteriorly to it there is no urinary bladder. We know that we go a little lower, so it must be female urethra here. Here, of course, the vagina, located a little more posteriorly, and the rectum. At this level we have also a tuberosity of ischio. And of course a femur. Yeah. And here. The mid-sagittal scan section through the female pelvis shows also the topography of those structures. So as we observe, we can see the rectum, the urinary bladder, and between those two must be, of course, the uterus with the body, with the uterine cavity. Of course, we have also a cervical canal, and a vagina with anterior and posterior wall. Of course, we have also a urethra extending from the base of the urinary bladder and opening to the vestibule of vagina. And this is a male pelvis. We have a rectum, of course, we have urinary bladder, and there is nothing between those two structures except those that lies below the urinary bladder. So we have a prostate here. Knowing that we are in the mid-sagittal plane, we can't see seminal vesicles. If we go a little to the both sides, there will be seminal vesicles also visible. And we have urethra starting from here. So this is the internal urethral orifice of male urethra, and approaching the components of penis. So we have a corpus spongiosum and corpus cavernosum. This would be the right one, because the left one is here. Turns a little to the right side. And if we go a little to the right side, we can see structures such as seminal vesicle. So this is the right seminal vesicle, to be more precise. We can feel it while examining per rectum, just above the prostate, especially when it's enlarged. And of course the external anal sphincter, which corresponds with this area. And once again, the components of the penis. So we have a corpus cavernosum, left one is here, and the right one, and of course unpaired corpus spongiosum. And knowing that we are a little to the right, we have also a right testis here. And the transverse scan through the male pelvis, you can see both corpus, left and right corpus cavernosum. Also, this is a part that contains different ducts. So this is the spermatic cord here, right, and the left one is here. And of course also the bony structures, such as femur and tuberosity of ischium. And that's all. Do you have any questions? Okay, so now close. And the second one is cervix, yes, of uterus. It's at the border between the wall and the cervical canal, so it's, if someone wrote the cervical canal, it will be also correct. Cervical canal, uterus, of course. And this is the body of uterus. Funds will be on the top, somewhere here. The cavity expands to the horns of the uterus, so it points at the level where uterine tubes enters the uterine cavity, and the both sides on this level. So this would be a body, more precisely. You can add posterior wall, but it's not necessary. The body of the uterus. Posterior is the intestinal wall, yes? Vesical and intestinal. And the four is urethra of female urethra. Female. Yes. Or you always have to distinguish the sex of urethra. And the last one is corpus spongiosum of the penis. Okay, thank you.